To PGH. Oh, hi. Good afternoon, House Healthcare. It is April 14th. And we have with us, so S-142, which is the licensing of pathway of licensure for internationally trained physicians. We have with us Dr. Greenberg from the Board of Medical Practice. So you want to come on up? Nice to see you again.
Thank you for having me back. So I think everybody was here, but my name is Matt Greenberg. I'm an emergency medicine physician. I work here in Central Vermont. I am the chair of the Vermont Board of Medical Practice. I was asked to come here today a little bit to talk about the position of the board on S-142, an alternative pathway for licensing foreign medical graduates. I think what I should start off by saying I am not an expert in licensing. I'm also not a global scholar. So some of the specifics are a little bit out of my realm. What I can bring to this conversation, though, is sort of the very robust conversation the board had regarding the bill, as well as my own experience on how I became a licensed physician here in the state of Vermont. I think when we're talking about an alternative pathway, it's really important to understand what the regular pathway is, and I'm not sure if that's explained yet. So I figured it might be worth just spending a minute or two with that. So currently we have US trained physicians and foreign trained physicians that become licensed physicians in this country, right? The way that most US trained physicians do that is they graduate high school, which is accredited by some organization and the federal government. They go to a 4-year undergraduate college, which is accredited by somebody in this country. Then they go on to medical school and do 4 years of medical school. Again, medical school is accredited by the US ACGME, sorry. And then they go on and do a residency. Residency is typically 3 to 7 or even 9 years for certain specialists. The first year of residency is also called an internship. That can be kind of confusing. But the first year of your residency is an internship that means the same exact thing. Usually done in your specialty, but occasionally it's done in a more broad general category. So high school, college, undergraduate, medical school, residency. So in addition to having all of those educational bodies, all of which are accredited through multiple organizations here in the United States, there are exams. You know, there's the SAT to get into college. There's the MCAT to get into medical school. Once you're in medical school, there's a USMLE, the United States Medical Licensing Exam, which is a 3-step exam. Typically, you take your first step somewhere around the 2nd year of medical school. You take the 2nd step in your 4th year of medical school, and then you take the 3rd step after your internship. And each one of these sort of tests your level of knowledge in general medicine, first the basic sciences, and then the practice of medicine, and compares you to your peers, your colleagues across the country, to make sure that you are living up to the expectations, even more so than just your training. So that's how a US trained physician would become a physician currently and get licensed. Once you do all of that, then you still have to go to a licensing board like the Vermont Board of Medical Practice. You present all of your receipts, all of your credentials, all of which are easily accessible, mostly online nowadays, where you can go to these organizations and get verification of all of these things. That's a very important step in the licensing process by the Vermont Board to make sure that we're certifying appropriately trained physicians. Now, there is a way for foreign grads to do that same process, where they would attend medical school in a foreign country and then come to the United States and do a residency in the US. And that is certified through other organizations. EFCMG is the big one. So they can still do that and then become licensed. But again, there's this credentialing step throughout the process where people have these certifications that are easily accessible and verifiable for us as a licensing entity to come back and say, okay, you've done everything that you need to do. So that's the process. And what we're talking about is going around that process to provide an alternative pathway for physicians that have trained outside of the US and not done a US residency. That's the primary difference, I think, for the most part, what we're talking about. In general, the board was very much in favor of the philosophy behind the bill. We have unmet need in this state. We all know we need more physicians, and we have physicians that are not practicing at their skill level or practicing at all in medicine that potentially could provide care, and that would fulfill two needs. It would help the state, the citizens of Vermont by providing medical care. It would help them and their families because they would be productive in the areas that they have trained in. So it seems like a great idea. The concerns that the board have really has to do with the details and how that would proceed. The primary goal of the board is to verify that we have safe, competent physicians providing safe care to the citizens of the state of Vermont. And so how do we do that in a brand new realm, a totally different process that's ever been done in this state before? Now, this bill, I had testified on this bill when it was still on the Senate side, and it was very different then, and it has been changed. And then there was another change that was recommended by the Department of Health. I'm not sure where that stands in this committee, but basically, if I understood the changes correctly when I read it, it was that it didn't lay out the process as much as it empowered the Department of Health and the Board of Medicine to meet and come up with a process that was appropriate and have an answer by January 15th of 2027. The board was very much in favor of having more time because we think this is going to be an in-depth process. Some of the concerns that we have is the idea of being able to verify credentials. Currently, all the credentials that we verify come through organizations within the United States that are easy to access and get those credentials. It is potentially much harder to verify that somebody went to medical school in Shanghai or Egypt or any other country on this planet that doesn't participate in some of the larger organizations, such as the organizations led through the WHO, World Health Organization. So we have concerns about being able to verify things. There were some concerns about it wasn't explicitly laid out that these people would be already certified to to be employed within the United States. So I think that would be important so that we're not necessarily trying to get people in like on J-1 visas, which are very expensive or anything like that, to come to apply for this program, but that we are supporting the people that are already here and are already qualified through Department of Immigration, et cetera, to work, which is obviously a very complicated process and has challenges, especially currently. We have concerns about the money. Who is going to pay for the training? Currently, so I think the original bill sort of suggested that these people would be treated like resident physicians. Well, resident physicians are supported through federal dollars to the tune of about $100,000 per resident per year. That's supported through CMS. So where would that kind of similar funding come from? And that's both to pay for the training of the trainees as well as their salary during, this training period. So there's some concerns about that. We had concerns about sort of what would happen to them after training. The concern is that most employed physicians these days are board certified. It's really hard to get a job if you're not a board eligible or board certified physician. These people would not be board certified or even board eligible based on any current guideline. And so finding a job, like right now, University of Vermont Health System, you have to be board certified to be employed by them. So the way that the current workspace is situated, there would not be, it is unlikely that they'd be able to obtain a job easily. And what we don't want to happen, or we'd have concerns that they'd be taken advantage of, and that the jobs that would be available would be for-profit companies like Hims or Hers doing online medical exams to sell, the designer drug of the day. And so we'd really want to make sure that, because that's basically medical servitude, and we'd want to make sure that there was an existing system for them to fall into, because training them and then leaving them without any job or any decent job is not what we want either. The board had concerns about liability, and that would be liability during training and liability after training. Do we know that if somebody is certified through one of these alternative pathways, that they'd be able to get malpractice insurance? Would the organization that they'd be working for be able to get malpractice insurance for them? And that would include during the training process as well as after training. I think that was a lot of, there's so many details in how you train a physician from start to finish, and making sure that we do it right, because we're building on a system that doesn't exist. The current system, is well funded, it's well thought out, it has a lot of credentialing behind it. I know that there are many states that have already approved this type of pathway. I have heard that there's only a handful of physicians that have made it through. I think it'd be very important to look at those programs and see how they have worked out and those physicians. So having more time to do that is definitely beneficial. I think one other thing I didn't mention earlier is just, this is a large amount of work for the board in its current iteration to take on. Currently the board has 16 volunteer members. It has 7 paid staff. That includes 2 investigators and the executive director. We maintain about 6,000 licenses currently. And we do almost 1,000 licensees each year, which is an initial license. Some of those, about 300 of those, are temporary licensees, are limited licenses for residents. The rest are for docs that are trying to get licensed here in the state of Vermont. And the overall budget's about $2 million. So with the current resources, it would be very difficult to add on this amount of workload. And so building in some sort of payment structure into how we plan to move forward with, the amount of legwork it's going to take to credential and set up these programs, verify that the trainers are appropriate to be training. That's the majority of what we were discussing. I think one other thing I was forgot that came back on one of the comments was the amount of time that somebody has been practicing and how long it's been since they practiced. The original bill mentioned 3 out of the last 5 years. I know somebody who testified previously recommended changing that to 1 out of the last 7. I think that's a poor idea, to be honest. I can tell you that if I go on a 2-week vacation, I feel very rusty coming back. And I can't imagine trying to practice medicine after a 6-year gap. As it is, all of our current licensees have to justify anything over a 3-month leave at any point during their career. And so that's usually considered significant. So when you start getting into multiple years without training, I won't say you're going back to starting all over again, but you're pretty close. I can't even tell you how much medicine has just changed in the last 7 years. So we have some concerns about the details. I think the philosophy is great. I think there were several members of the board that were very eager to participate in further investigation. But it's going to have to be done carefully and mindful of protecting the citizens of Vermont and the people that we're trying to get up to speed.
Did you see the language that Lauren Laban submitted to us last Friday? Essentially that you all would go through the rulemaking and you would be the ones answering all these questions that you have just
Yes. I did see that.
rather than us prescribing to you.
I did see that. And I think that's probably a better approach. It's not easy. It's not going to be easy. And it's going to take a lot of work hours to do this.
Daisy?
Have you read the latest version of S-142?
The latest version as of last week before
Passed by
that,
the Senate.
yes.
Because I just have a couple questions. One, you noted that you were concerned about validating credentials, and I thought I also heard you say that currently we have foreign trained physicians working alongside physicians that are trained in the US here, and they've been assessed by the ECFMG.
Correct. They would be certifying that they've done medical school. But there isn't currently anything to certify anything above that. The original bill, and I can't remember if it was taken out in the second. I apologize, I've read too many of these. Where they were talking about being in practice in their own country for so many years without any infractions. That is a much harder thing to figure out. So we could verify medical schools through all of those that cooperate with ECFMG. And that's.
But the credential verification is not an entirely new process. We're doing that now so that you can accept people for residencies who have gone to medical school abroad, correct?
We are not.
The ECFMG.
ECFMG does, yes.
And then liability insurance is something you mentioned. These individuals in the bill, it says that they would only be eligible for this program if they were already offered employment, which means that they would not be requiring any money from CMS for their residency, the $100,000 you mentioned. They would actually have an offer of employment, which would pay them. And because they're provisionally licensed, they would, I'm assuming, be able to bill, and they would also then fall under the employer's liability insurance, right?
If the employer could get liability insurance. And that's what I'm saying. I mean, this is way outside my realm, but I'd be concerned as an employer trying to take on a resident or a trainee that is really an unknown in many ways. And unlike that, I don't know how that would affect insurance rates. They would not be able to bill. It'd be up to the employer based on the way that the bill is written.
And then the
Correct.
other thing is, you mentioned something about the medical exams, and this bill says that the applicants would have to pass both step 1 and step 2 of the US medical licensing exam.
Right.
In addition
They have
to,
to pass that before entering the program, I believe is what it said, and then the step 3 upon before completion or something like that.
right, so there would be significant hoops in addition to them having already gone to medical school. They would have to take our exams.
Correct.
So I don't know, does that make you feel at any level of comfort? I mean, if someone had only practiced 3 of the last 5 years and then they took step 1 and step 2, can you speak to that? In terms
Yeah,
of
so
their competency?
I think it is reassuring. I think it does verify that they have at least some baseline knowledge. I'm not saying it's impossible to do it. I just think it's challenging. I mean, it's a lot of knowledge to know, and any gap in training is time that knowledge kind of disappears. But I think it's very reassuring that those things are in there because they help stratify and make sure that everybody is sort of on a more similar level.
Good.
Yeah.
Yeah, I'm worried about quality and safety as much as you are, don't get me wrong, but some of your comments made me wonder if you'd seen the recent draft.
Any other questions? Okay. I think in a lot of your comments, I'm sort of this sort of theme of systemic barriers that are in place that the bill doesn't work because of pre-existing systemic barriers. I mean, if we had enough residency spots, this wouldn't be, because they would be international students just like any other. And, do their, what is it called? The
ECFMG?
the 1 and 2, all the tests they have to take at various levels. And you were talking about that would they even be able to have employment because they wouldn't be board certified. So there's a systemic problem of why are we only hiring board certified? And not to mention why couldn't they become board certified? That's not like our problem or your problem. That's the boards of the various specialties, not, all they would have to do is open it up. So, I mean, that's another barrier. It seems like this bill is just sort of asking us to utilize the talents and the experience of people who have come to this country for whatever reason and maximize the talents of everybody that's here, of all of us. And I just don't feel like we should be just saying, well, we can't, because we have all these other, again, systemic barriers, frankly, to, I can't believe all the amount of time I've thought about the whole structure of medicine in the United States, frankly, around the world also. I don't know, I guess I feel as though the language that Lauren Lehman presented to us really sort of gets around this, so that you guys can work collaboratively together to really think out these questions and, try to figure out and remove some of these barriers. And for the good of all of us. I think I read in some meeting minutes that it's anticipated that maybe this would only be 10 people a year. 10 providers a year. That's a lot. I mean, that serves thousands and thousands of patients. We have such trouble recruiting and retaining physicians as it is. I guess I just feel like we should be doing everything we can to remove some of these barriers and support our healthcare system. I guess I don't even really have a question. I mean, you're welcome to make a comment. I guess I think it was more a comment.
Yeah, no, I think you're right. I think the hierarchy of medicine is very complicated, but over time, for a variety of reasons, people have decided that the standard level of training is board competency, board certification, which equates to residency training. 30, 40 years ago, you could go to med school, graduate as a doctor, and then go out and start your own practice. You didn't need to do any additional training. You were a GP and that was good enough. But at some point in our progression, we decided that wasn't enough, that you needed more. And now you need specialty training, and now you need subspecialty training. So it has gone out of control, you might say. So I totally agree with you there. And I do think that the proposal from the Department of Health, where it would be up to us to come up with a program, is a much better approach than trying to lay it out right now, because I think it's going to take a lot of time to figure this out. I'm not saying we can't do it, because if we're charged with doing it, we will do our best. I think it's going to be a challenge, and I just worry. I worry that the way the system is set up, like you said, there's so many barriers that's going to be pushing against these individuals.
I think in the meeting that I saw of your board, you called it an insurmountable task. So I'm concerned, to be honest, that if you go into rulemaking, you are not going to follow through on this or support it.
I think it'll be supported, but I think there are some things that are out of our hands. Whether an insurer is willing to pay, whether there's anybody in the state that's willing to hire anybody without funding. I mean, I think that's a huge question.
Well, then they're
Yeah,
not
we-
eligible, right? Like, I
What's
think
that?
it's beside the fact, because according to this language, they wouldn't even be eligible for the program.
Well,
Like,
that's what I'm saying, but if there's not an employer in the state that's willing to take this on, to hire them, then the program's dead in the water right there.
well, we interviewed several physicians over the summer. I spoke with 6 who were willing to hire them and support this bill.
We will try if that's what we need to do. I mean, we will put it together the best that we can, but I think there's a lot arguing against it. I think it's going to be hard for those individuals, but they've already been through a ton. So we will do whatever we can to make
They
it.
have, and I mean, I'm sorry to sound frustrated, but I've only heard the board arguing against it. I've interviewed and spoke with 6 different CEOs of medical providers, leading medical providers in our state who enthusiastically supported this, who are working with foreign trained physicians right now. And yes, they didn't do their residencies there, but they are either not providing care to Vermonters or they're willing to support this, and some people, I think that's kind of the choice that it boils down to. Are we willing to address the systemic barriers and allow oftentimes more qualified individuals to come into our state and, do the things that it takes to demonstrate that they are able to deliver care to our standards and quality through taking our licensing exams and through having provisional license. But I don't know, it's just really frustrating to have the NAACP and the World Education, what's their last, I forget the last word of it, but Wes, have worked for years on this legislation. And I don't know that the board has collaborated with them on it or why it's taken years to get to this point and it's still an insurmountable task to the board.
Yeah. I mean, I think part of it is look to the other states that have already approved this, and there's very few physicians that have made it through.
We were told that New York is passing 85 per year. Are you saying that's not true?
That was through what I would understood was that's a slightly different kind of program. Yes, New York is by far the one, and that's been in place for many, many years. Their program involves 7 different committees, including the Department of Education and the Department of Health that do it. And I don't know that much about it other than that. And I know New York is the other one. I was referring to some of the more recent ones that have there's 17 states that have passed in the last couple of years that have a more robust, I guess I would say, training program for physicians. Again, I think it's a great idea. I just think that there's a lot of barriers that are going to be difficult. And if there are CEOs in the state that are willing to support this, then I give them a lot of credit because, I think it's going to be a challenge. But if they're willing to do it, I haven't talked to any of them, so I don't know.
I'd be happy to put you in touch.
Yeah.
Wouldn't it be prudent to utilize the experience of all these other states that are doing it? And I mean, wouldn't that actually make it less challenging?
Yeah, and that's why I think
reinventing the wheel
having some
just
more time to see what's going on over the next couple of months is definitely very helpful.
Leslie, you had a question?
Yeah, thank you. I mean, I'm just hearing a very negative position from you. And I worry that when things come from that negativity, it's a self-fulfilling prophecy. And we did hear from a CEO who was very enthusiastic and willing to support. They want primary care, they want more jobs and need more jobs, especially in our rural areas, which I know you know. So if you and your board come to it as an overall negative, insurmountable problem, that's, as I say, a self-fulfilling prophecy. So how can we think about it? How can we shift that? Is there a way to do that? To have you and your board, I know, having watched many people go through medical school, I get it. I understand it. We want to be cared for by people who we can trust and we know are competent. But we're not the only country in the world that creates competent physicians. And that is something that I think we need to accept. And I'm hoping that maybe you and your board might be able to, I don't know, revision, let's say, the approach as we go through this step process. If it doesn't work out, it doesn't work out along the way. But to not do something because it feels hard doesn't seem, and because that's all I'm hearing from you. This is hard, and this is hard, and this is hard, and this is hard. And yes, that's probably all true. But we can do hard things. Yeah. And we have to do hard things in order to solve what we have as a serious workforce problem. So this is a potential opportunity, as our chair said, where thousands of patients might get care. And we, of course, want it to be safe and competent care because we may be their patients and our children might be their patients. So I'm just wondering if you and your board could, I don't know, relax.
I guess what I would say is that I'm not trying to be necessarily pessimistic. I'm trying to be realistic.
But is it realistic? That's what I'm pushing back on. Because your idea of what's realistic, what I'm hearing is that it's too hard to do. And I'm frustrated by not
It's
being.
hard to do. I think that having that extra time period when before the first version had us doing things like right now. And I think that having these several months to meet and come up with better ideas is definitely the way to go.
You mean the new language from the Department of Health?
Correct.
So, okay,
Yes.
yes, and I think we're going that way,
Yeah.
direction, so,
I
right?
have Val and then I have Alan.
Hi, very simply, if we were to take the barriers and put them on a scale of 1 to 5, financial, one of them, the ask, right, the training, is that, where would you put that?
Where would I put the financial part?
Yeah, is how large is the barrier?
4, 3 or 4, probably 4. But if you've spoken to people that are willing to support it, I have not heard that. I hear all kinds of budget, I'm in budget meetings all the time about how hard it is to find any money in healthcare in this state right now. And this is a cost, and looking at it from a cost analysis viewpoint, it is a little bit of a gamble.
I see you, Alan, but can someone refresh my memory? We've had Michael Costa in here so many times recently.
Yeah.
Was it Michael Costa
Yeah.
that was the CEO?
Yeah.
No, not Copley, Gifford.
Oh, get it, okay, yeah.
And, also talking about their Maple Mountain Consortium residency and how this would fit in. Go ahead, Alan.
Basically, the same as Val, is the financial burden of this. And we do need more staff to do the vetting process, what do you envision on all this?
Yeah, I think probably they would need more staff. Like, I'm not in tune with the board's budget other than the total number and where it gets divvied up. Right now, the board is supported by the license, or to some degree supported by the licenses. Each one of us has to pay, if it's a new license, $650, if it's not, $550 every couple of years to help support. It's not fully funded. There is funding from the state as well. But I have a feeling when you're adding on an amount of workload that you probably would need to do some additional funding.
Can I expand on that a little bit, just because I want to make it very clear, what you're referring to? Are you referring to the board would need an appropriation in order to do the first steps with the Vermont Department of Health to go through rulemaking and come up with a plan? Or are you saying that once you had done that, you would then need appropriation in order to implement it? I want to be clear on where you're saying it's going to cost you money.
I would say the latter, but I'm not the executive director and he might have a different opinion than me.
Okay, because
We already have a group there were 5 volunteers that were very interested in this, in helping work on the rule process. So I think that we can probably get through that. Again, I'm not David, so.
okay, I just want to be clear because
Yes.
Lauren Lehman was very clear that they did not need an appropriation.
Okay, good. Yeah, I don't think that part would. I think and based on what we created, might require some more manpower. And I think that's part of the analysis that you do when you come up with a plan.
Yeah. Okay.
That's if we amend the bill.
Yes. If we amend the bill. So there would be no appropriation in this bill if we did it as amended. Okay. Any other questions? Great. Well, thank you.
Thank you.
for joining us again.
Much, it was very helpful.
Let's see. So, but just for the record, on 142, which we just heard on, we are, Jen is coming in tomorrow, Thursday morning. And she's going to, we've got markup. She's changed some things around, as we had discussed with with Lauren's testimony last week. And then we're just gonna have a little bit more testimony, and I have it warned as markup testimony and a possible vote on this bill. So
Thursday.
on Thursday morning, 10 a.m. Okay, so we are moving on to 154, which is the biomarker bill. And Jen, if you want to come on up. Sasha, did we, okay, posted the draft, and we don't have Nolan right now. But, well, let's see the draft and then I'll sort of give the background for the other. Is that passed by this?
Jen Carvey, Legislative Council, you should have S-154, draft 1.2.
Oh, I'm on the wrong day, no wonder.
And we'll put it up on the screen. It's draft 1.2 because I'd made some changes after I did a first version, so I just made it 1.2. There isn't a 1.1 floating around anywhere. All right, so we are looking at S-154. This is a strike-all amendment, so I've done standard markup with highlighting. S-154 is an act relating to health insurance coverage for biomarker testing. And so this is reflecting some of the testimony that you heard last week from DFR. So this would still require DFR and the Agency of Human Services to analyze the costs. We have definitions still of biomarker and biomarker testing, but it would strike out the definitions of consensus statements and nationally recognized clinical practice guidelines because those terms are struck in subsection B. So this is directing DFR and AHS to analyze the costs associated with requiring health insurance coverage and Medicaid coverage for biomarker testing for purposes of diagnosis, treatment, appropriate management, and ongoing monitoring of a patient's disease or condition. And the test is supported by medical and scientific evidence, period. And then it gets rid of the including all those 1 through 5, which is where those terms, number 5 is where those terms had been used. Period. And then it still has DFR and Agency of Human Services reporting to this committee and Senate Health and Welfare, and in the case of DFR, Senate Finance. On the costs associated, the editors, when looking at the rest of the language, noted that I had missed services for CMS, so adding that in there. And then section 2 would appropriate $10,000 to the Department of Financial Regulation in FY27 for the analysis. I changed the effective date of the act to the first day of FY27.
26? No.
First day of FY27.
Okay.
So it's July 1st, 2026 is the first day of fiscal year 26.
Okay.
All right, so just to give a little background on the section 2, and I will ask Nolan for an updated fiscal note, but in reviewing this morning for this new draft, if you remember, Mary Block from DFR had come in and had testified on this prior to making changes to the scope of what DFR was looking at. And at that time, and she had mentioned that it would take resources from DFR to be able to do this analysis on the defrayal and, much it would. Nolan had previously had a fiscal note on it, but since we have gone and removed the extraneous things that DFR said, yes, thank you, Jen, for giving us a visual representation of 1 through 5. Went back to DFR again today and asked if they would still need appropriation. They felt as though there's JFO, and JFO is going to get us an updated fiscal note. And so they've indicated via email, and we will get that in testimony also, that they just now need 10,000, which we weren't aware of, but it's 10,000 now. So that's why Jen has included this in there. So if we were to vote this bill out, it would then go to appropriations, who would make the decision on whether or not they would like to move forward with it. So there's the history of section 2. Any questions on this bill? Any thoughts on it? Does anyone want to think about it some more? I have it warned on our schedule for markup and possible vote. This was the markup.
This is the markup here?
Yeah.
And what are you thinking of voting?
I was thinking of voting unless people needed time and they wanted to consider and sit with it and or ask more questions, or frankly, we need.
Right, at this point, just to summarize.
It is a study asking DFR and AHS to analyze the costs that would be associated with coverage.
How do you determine which vital markers are included?
They're gonna do the assessment, right?
No, but how could they do that? I mean,
I think there's a whole science around actuarial stuff that
there's a slew of them.
they would probably look to other states. They would look to,
If they come back and they say, hey, it's gonna cost you $20 million a year if you do biomarker testing of the BRCS gene or whatever, then we'll get to make a decision of whether or not we're gonna mandate insurance companies in Vermont do that or not. So that's what I understand the bill is gonna do. Is that right, Jen?
It's asking them to come back with an estimated amount of insurance. Coming up that, right, estimated amount that insurance premiums would increase and what it would cost for Medicaid if Vermont were to enact legislation requiring health insurance coverage of biomarker testing. So I think they will have to determine the set or sets that they are costing out. So that will be part of the information that you should receive.
We're not doing any decision other than telling them to go study it so that we can make a decision of whether or not to cover it.
But there's a fiscal note of $10,000 to do the study.
DFR indicated in order to do the work around the estimating the costs of defrayal and premium increases, that they felt as though they would need additional resources. And Mary indicated when she was in here today, if you remember, that there is a CMS, what's it called? A notice or a
Director's notice.
a directive out right now that possibly states would have to take everything that they have expanded, and from this point going forward, states would then need to pay for that expanded coverage.
From this point forward, from this point forward, but going for mandates going back to 2012.
Yes, we would pay going forward. We wouldn't have to repay
Right,
everything
we
from
would be
2011.
retroactive.
Every single thing that we've expanded since 2011, even with.
The notice of
Permission.
payment parameters thing.
So I need help getting that. So, but going back to 2011?
So it's not super relevant in the context of this bill, so I don't know, if we can look at it.
It's relevant to the appropriation, is that they feel as though they're going to be doing an enormous amount of work around this, based around another thing concerning defrayal, and that they don't have the additional resources to then do this on top of it without having a little bit more.
So what are we opening ourselves up to?
More money.
Nothing.
We're not doing anything.
Unless we get the report and go from there.
Right, on this one, right?
Yeah.
Dave, and then I got Ken.
The fact that it's a study is okay with me. I am concerned with how they're gonna be able to come up with a fairly accurate number of how much it's gonna cost. because this biomarker testing, it's not limited to any disease. And we don't know how many diseases it's possible to test for this. So I'm concerned with the overall cost and whether we're going to be able to estimate how much it will cost us.
I think that's that section essentially that says that DFR and AHS, it tells them to figure out the cost for purposes by using biomarker testing for diagnosis, treatment, appropriate management, ongoing monitoring, as supported by medical and scientific evidence. I personally cannot speak to how they're going to do that. However, they seem pretty confident that they do this sort of stuff all the time and that they could do it.
Yeah.
I have Karen and then Alan. Oh, go ahead, Alan.
My concern's the same as Dave's, because, you know, we talked about at the beginning of the year, affordability of healthcare. We don't know what this is gonna cost us if we continue after the study. We don't know, I think the prosthetic bill's coming back, where we're going to demand health insurances more. We got primary care that we're gonna get a payment per month per person. What are we doing to healthcare affordability here?
I just have to correct one thing. Prosthetics bill?
It's in the Senate, right?
No, we didn't do that bill.
Well, they've got a bill that
We're
might be
writing a
coming.
letter.
We're writing a letter.
You can look at.
We wrote a letter to the insurance companies
Okay, I
and
didn't know that.
the prosthetics people to say,
Okay, so I didn't know
go
that.
chit chat with each other. That was it. We did not do that.
But this
And-
does nothing to,
But this doesn't do that
It
either.
doesn't yet.
But
We're doing all these studies, but eventually they're all gonna cost money if we implement.
well, this is basically the study to say how much would it cost?
I understand that.
So, well, I'm confused about, I mean, maybe I'm just like, how do we ever really make decisions about what we do if we don't take the time to get accurate information on what something would cost?
I know, but it seems like we just a minute ago, we talked about 142. And we asked him how much it would cost if we had more staff. That's cost to healthcare.
But they wouldn't know how much it would cost.
I do
until
understand that.
they
Maybe it's the
develop
fear of the
what they're
unknown. I
doing.
don't know.
I-
Maybe it's just the
That's
fear
a
of
real
unknown.
fear, the fear of the unknown, but I guess my question to you is, does that mean that you never ask any questions? You don't want to ever know the
No,
answer?
but I look on past policies in our practices. What have we done to make healthcare more affordable here?
What have we done to make healthcare more
We've
affordable?
done some.
This committee last year is responsible for a bill that saved almost $200 million out of the system last year. We have another bill on our wall right now, S-190, that proposes to also remove tens of millions of dollars out of the system.
Where does that help the public's pocket?
Well, I will tell you that premiums were anticipated to go up
Yeah,
20%,
I understand.
and they were increased by, what was it, 3, 2?
Okay,
That bill we did last year on the price cap, the teachers' health insurance, Blue Cross Blue Shield had come in and put in the premium, and it was 7% higher. We did that bill, and the next day, they came back and they said, hey, it's only 3% now. That's every taxpayer, property taxpayer in this state. That saved the teacher's health plan tens of millions of dollars. And we're still doing that.
well, thank you.
I,
Well, I appreciate it.
Can I say something?
Yeah, go ahead, please.
I have,
Leslie.
I have to say 142 is money spent that we're expecting something in return. And for that reason, I'm willing to, I think that's an investment. I have a little bit of an issue with 154, and I'm going to tell you why. I think they do biomarkers already on cancer patients. I think that's something, and I know this is just a study, but God, we do a lot of freaking studies in this place, and I don't like this bill. I was just gonna say, I just don't like this bill, and I just don't think that it's, and I'm not saying that, I think that there's probably patients that will benefit from this, but as far as I'm looking at the greater scheme of things, we already do it for people. And if there is a study, I think that it could be something that happens in the future. That's all I have to say.
To your point, because it's a good point. We already cover biomarker testing
I
in
looked it up.
Medicaid and commercial when it's considered medically necessary. And I think that what we're finding is that year after year, or as technology advances and tests advance and scientific evidence becomes that more and more covered because they are medically necessary. And so,
I looked that up this
Yeah.
weekend and I agree.
but there's also a case to be made of, this is an emerging technology, which is incredibly expensive and advancing at rapid rates. And perhaps there should be analysis on what we're facing in the future, because these will be medically necessary and required to be covered. Maybe we need to get a handle on what we're facing in the future. Daisy, did you have a?
It was Leslie.
Oh, it was Leslie.
I'm confused too, and I'm trying to understand how it intersects with the practice of medicine. And, I was listening to the biomarker testing with dementia. And, okay, so you do the test and you find out at 50 you have the biomarker, and then what, I'm worried about it being, this is my cynical self standing up here, about it being a boondoggle a little bit of, lab testing and pharmaceuticals who want more prescribing for things that we don't even know work. So, $10,000 is a small amount. I think the DFR budget's like $20 million. It's hard for me to believe they couldn't find $10,000 in their $20 million budget to pay for this.
Things are emerging so quickly. It could be a study that's obsolete in 5 years.
So I'm just trying to understand where the motivation is behind it. Is it coming from Alzheimer's pharmaceuticals? And that worries me.
Thank you. So I'm not going to take a vote on this. We have Dr. Leffler you can ask him how we've saved money, because he's.
You'll tell us. You'll tell us.
He will tell us. So we have him at 3. I think let's take a break until, I don't know, 2:45. We take a long break. And
Ain't it warm in here?
let's take let's take a 5-minute break and then, and we'll be right back.
We should have left you guys.
Back for a minute. I just had a thought, but I want to like get with, Ledge Council.